So welcome. Welcome to the ERA EDTA CKJ Journal Club. Each e-seminar takes place on the last Thursday of the month at 1700 Central European Time, 1600 UK time, and we pick out a topic from a recent CKJ original research or key review article, and the authors will introduce their work. There'll be at least one expert of the field, and we've got three today. We're spoilt, but it will be moderated as well by CKJ Editor-in-Chief, Professor Alberto Ortiz, and/or myself, Will Herrington, an Oxford-based nephrologist and epidemiologist. We'll talk for an hour. It'll be fairly informal, and we'll encourage live questions from the listeners in the Q&A type box from Zoom, but also thank you for sending in your questions beforehand. It's being recorded. It will be made available on various video platforms afterwards, so keep an eye on social media for links. Now, this week we are presenting our fourth e-seminar, and for the first time we are focusing on peritoneal dialysis. Now, I have to say I've always had the greatest respect for anyone who goes through the blood, sweat and tears of randomizing and completing a trial. So it's with great pleasure we have primary results of a trial of extended antibiotic therapy in peritoneal dialysis associated peritonitis, a trial which recruited 250 people. And Professor Szeto, who is happy to be called CC, from the Chinese University of Hong Kong, is the lead author and here to present the results with us. He is also responsible for the previous preparations on guidelines for the treatment and prevention of peritoneal dialysis related infections for the International Society of Peritoneal Dialysis. So welcome, CC.
Thank you.
And I said we're spoilt for choice with the expert panelists this month, so we're really grateful. Professor Davies, from who's Professor of Nephrology and Dialysis Medicine, and also a former president of the ISPDN, for joining us from the UK. From Canada, we have Dr. Perl, Jeff, who is a nephrologist at St. Michael's Hospital, and an assistant professor at the University of Toronto. His primary research interests on improving survival and quality of life for patients with peritoneal dialysis, and is a primary investigator for PDOPS. Thank you for joining, Jeff. And we also welcome Assistant Professor Dr. Muthana Al Sahlawi from the King Faisal Hospital in Saudi Arabia, who also works on PDOPS and performs meta-analyses of trials and observational studies in peritoneal dialysis-associated infection. So we're grateful for all of your time today.
Thanks, Will.
So, CC, before we start your presentation, I always like to hear about what inspired you to get into the field. So what inspired you to get into the field of peritoneal dialysis, and particularly what was the specific trigger for you to want to take on the mammoth task of a randomized trial?
Well, some of you may know PD is, we have the PD first policy in Hong Kong. Unlike most part of the world, new dialysis patients in Hong Kong are put on peritoneal dialysis unless they have a medical contraindication. So we have a whole lot of PD population. And when we first start our program nearly 30 years ago, so the literature was very limited. That's why I have the interest to learn everything about peritoneal dialysis, observing our patients, see how they are doing, describe their behavior, and try to learn a bit more. But with time, descriptive data may not be sufficient. Say, for example, for this particular study, the objective of the study changed when we tried to design the study. So at the end of the day, we decide to go to a very basic question: how long should we treat our patients? Because it's recommended by the guideline, but actually the duration of treatment is not based on any scientific evidence as such. So we really want to see whether we are giving an adequate treatment, or whether we can give a longer treatment and see whether that could help the patient.
That's great. So so without further ado, I think you should go straight to your presentation, and we'll gather our questions for you. So hopefully you can share your slides and tell us all about the exciting results.
Yes. So can you see the slides? Yes.
Yes,
so,
I can see the slides. Go.
Great. So thank you. So the formal title of our study is Extended Antibiotic Therapy for the Prevention of Relapsing and Recurrent Peritonitis in PD patients. It's a randomized control trial comparing conventional versus extended treatment. Is conducted as a single center study in my unit. This is a disclosure of the conflict of interest. We had some research support from various groups, but this particular study actually is not supported by any commercial source. Now, just to give you a bit of the background, and peritoneal dialysis in Hong Kong is the first-line renal replacement therapy, but in many other parts of the world, at least is contribute to a considerable proportion of patients receiving long-term renal replacement therapy. And if you consider a peritoneal dialysis, and a proportion of these patients with time would develop technique failure and require to be changed to long-term hemodialysis. And a large proportion of the PD patients who require a change in modality is because of relapsing or recurrent peritonitis. In fact, infective complication is an important cause of technique failure. This is slightly old data, a cross-sectional study on over 40,000 PD patients, and infective complications account for around 45% of all the patients who develop technique failure and require a modality change. So for those who are not familiar with the terminology, actually there are clear definition of what we call a recurrent versus a relapsing or repeat peritonitis, which are the major conditions that are interested in the current study. Recurrent peritonitis means that after the completion of antibiotic therapy for the original episode of peritonitis, another episode developed within 4 weeks with a different organisms. While relapsing peritonitis is after completion of antibiotic therapy for the index episode, another episode of the same organism or being culture negative developed within 4 weeks. While repeat peritonitis is the development of peritonitis with the same organism at least 4 weeks after the completion of the antibiotics. Now, in this study, we do not touch about refractory peritonitis, so I will leave that definition behind, but we'll focus on recurrent, relapsing, and repeat. Now, the terminology may seem a bit confusing, and in fact, it's used to believe that relapsing peritonitis is the major problem. But our previous study actually showed that recurrent peritonitis, that is development of another episode with a different organism, actually seems to be even worse than having a relapsing episode. This is our old study reviewing over 300 episodes of a relapsing, recurrent, or ordinary peritonitis. To cut long story short, what we found was recurrent episode actually has a substantially lower complete cure rate and a much higher rate of requiring catheter removal or direct mortality. So it's not only a contribution to technique failure, but it's also a serious condition requiring catheter removal or even causing patient mortality. The next question in our previous research was whether we can predict the development of relapsing or recurrent peritonitis. This was our study published 7 years ago in CKJ, exploring the measurement of bacterial DNA fragment in the peritoneal dialysis efferent in patients with peritonitis. And what we did was measure the bacterial DNA level in the dialysis efferent 5 days before the completion of antibiotic therapy. And what we found was for those who subsequently developed relapsing or recurrent peritonitis episode, they had a much higher PD efferent bacterial DNA level before the completion of antibiotic. And the cutoff at that moment we could find was 1 copy of bacterial DNA per microliter, not mil, microliter. and with a 70-something sensitivity and specificity. Not great, but they indicate that there may be some bacterial fragment indicating the bacteria may still be persistent, which will precede the development of a relapsing episode. And that's why we went on and see whether we can do anything to reduce the incidence, reduce the risk of relapsing or recurrent or early repeat peritonitis episode. And the logical thing that we believe would be useful is that we see whether extending the duration of antibiotic therapy would prevent the relapsing or recurrent peritonitis. And with the light of the previous study, we also want to explore whether the bacterial DNA fragment in the PD urine would help as a guide to detect those high-risk patients who will be particularly benefited from extended antibiotic therapy. I can tell you our original study proposal actually was to detect the bacterial DNA content in those patients with PD peritonitis, and only for those who have very high bacterial DNA content, and randomize them to see whether extending antibiotic would help to prevent the relapsing or recurrent episode. But we found that that protocol actually did not work in the real world. So we end up having a randomized control trial comparing extended therapy versus conventional therapy for every patient, and we measure the bacterial DNA as you can consider as a confounding variable that we test. So what we actually did was over 2.5 years or so, we recruited 254 patients fulfilling the diagnostic criteria of PD peritonitis, and they were randomized to either a standard group of treatment, that is the duration of antibiotic, strictly follow the ISPD recommendation according to the causative organism. For those who are not familiar with the guideline, for those who have peritonitis due to coagulase negative Staphylococcus or Streptococcus or culture negative cases, they will receive 2 weeks of antibiotic, while patients with a gram-negative organism, Pseudomonas, Enterobacteria, Staphylococcus aureus, or Enterococcus, they would receive 3 weeks of intraperitoneal antibiotics. Versus an extended group, and depending on the causative organism, they would always receive 1 extra week of intraperitoneal antibiotics. In other words, for coagulase negative staph, Streptococcus, culture negative, they would receive 3 weeks, while for gram-negative Pseudomonas, Enterobacteria, or Staph aureus, Enterococcus, they would receive 4 weeks. And the primary endpoint of this study was relapsing, recurrent, or repeat peritonitis episode within 6 months of the completion of the antibiotic therapy. And around this time, we also measure their PD urine bacterial DNA level. Unlike the previous quantitative PCR method, this time we use a strictly quantitative digital PCR method to directly measure the copy number in our samples. So this is the consort flow diagram summarizing what we actually did or what actually happened. In fact, we screened 440 patients referred to us or presenting to us with label as peritonitis, and 186 of them were excluded. A large proportion of them actually because they didn't meet the criteria of peritonitis. 42 of them were clinically unstable. I'll explain a bit more later. And then only a few declined to participate. And then for those who fulfill the criteria, agreed to participate in the study, clinically stable enough. So they were randomized, and 5 days before the original planned completion of antibiotic, they would be randomized. 127 of them were to the standard group, so they received the duration of antibiotic according to the ISPD guideline. They were completed, and then they were followed for 6 months for the development of relapsing, recurrent, or repeat peritonitis. Another 127 of them were randomized to the extended group. So they, on top of the ISPD recommendation, they received 1 extra week of antibiotic therapy. Now, for the extended group, 2 of them died during this observation period. and 3 of them had failed antibiotic therapy. They initially improved, they were randomized, the antibiotic was planned to be completed, but then the peritonitis worsened again, so they require catheter removal or additional treatment. 3 of them actually turned out to have a mycobacterial peritonitis, and 2 of them, after completion of the antibiotic, developed fungal peritonitis as a secondary event. While for the standard group, 5 of them died for various reasons, and 5 of them failed to respond to antibiotic therapy. They initially improved again and then worsened during the course of treatment and then required catheter removal or other therapy. Now I may have to go through in slightly more detail about the high proportion of exclusion. 100, although we screened 440 patients, 138 did not meet the inclusion criteria. A large proportion of them actually were referred to us by our emergency room because of abdominal pain, actually because of some non-specific abdominal pain, blood stain, effluent, sepsis from another source, and labeled by our emergency room as peritonitis. So we screen them, we exclude them, and but 42 of them actually were, most of them were actually admitted to the hospital because of unstable clinical condition. They had high fever, lowest blood pressure, or other severe concurrent medications, whom we consider not a very good idea to recruit them into the study. So they were excluded. 6 of them declined to participate. So you may consider this particular group may introduce some bias, because we tend to exclude patients even with real peritonitis, were very severe, require hospital admission, even with severe sepsis or septic shock, and our study basically exclude this group of patients. And this is the comparison of the baseline demographic data of our patients, the extended group versus the standard group. I also include the 48 patients who have very severe clinical manifestation or decline to participate. We just list their baseline demographic data for your comparison. And to cut the long story short, on the face of it, they are very all the groups were very similar in terms of distribution of gender, age. You may consider the duration of the dialysis vintage may be slightly lower for the extended group as compared to the standard group, although it's not significant. Diabetes is very common. 60% of our patients had diabetes with a Cheuk-Chun comorbidity score of over 6. And for many parts of the world where machine-assisted PD is common, because CAPD is the major therapy in Hong Kong, only a very small proportion of our patients had machine-assisted PD. And one additional point to note is that for all these patients, during peritonitis, they were converted to CAPD with a continuous intraperitoneal antibiotic therapy. A substantial proportion of our patients receive glucose polymer or low GDP solutions. And the previous peritonitis episode number is very similar. And not included in this table or in our analysis in the publication is the residual renal function for this group. And from what I remember, they all have very poor residual renal function after dialysis for over 2 years. And the baseline residual renal function, I believe, is around 1 ml per minute or so. But I do not have the complete figure to show you here for comparison. Now, this is another important comparison about the distribution of organism. Now, for some of you who are aware of the distribution of causative organism worldwide, Hong Kong actually used to be famous for the higher than average prevalence of peritonitis caused by gram-negative organisms. But in this particular study, what we found was the distribution was more close to many other parts of the world. Over half of our patients had gram-positive organism as the causative one, including Staph aureus, and a large proportion of them actually were due to Streptococcus. Coagulase-negative Staph, on the other hand, was not particularly common. Gram-negative peritonitis only account for around 15% of our cases. And polymicrobial, on the other hand, is quite common. and culture negative was slightly more than 10%. The two groups were comparable. There was no significant difference, but when you go listen later, go through our result, you may, to determine whether our result could be extrapolated to other parts of the world, you must bear in mind the difference in the distribution of causative organism in different centers. Now, just some additional information I would like to highlight. Concomitant exercise infection in our study was quite uncommon. Only 8 patients in each group had concomitant exercise infection. And the majority of our patients who followed the ISPD guideline had cefazolin plus ceftazidime as their baseline and as their empirical antibiotic regimen. Obviously, they were adjusted according to the ISPD recommendation once the causative organism is identified. But this is the backbone therapy. For those who didn't receive this regime, in essence, they had cephalosporin allergy and they received vancomycin plus gentamicin. Now, although we say we randomize them to 1 additional week of antibiotic, but it is useful to review how long did our patient actually receive the treatment. For the standard group, close to 70 patients, the planned duration was 14 days, and 58 of them planned to have 21 days. And the actual duration, when we, after completing the study, go through the notes, the actual duration was 14.5 days and 22.4 days. So it's a reasonable compliance to the original plan. For the extended group, 66 planned for 21 days, 58 planned for 28 days, and the exact duration, that actual duration that they received the treatment was 21.6 and 28 days. So reasonable compliance, and therefore the planned difference in the duration of antibiotic therapy was 7 days, and the actual difference was 6.4 days, very close to what we planned. So this is the major outcome I would like to show you. And to cut the long story short, it does not seem to be very significant or encouraging. Now, if you combine the 3 major parameters for our primary endpoint, relapsing, recurrent episode, or repeat episode within 6 months, then 36 patients had the primary outcome event in the extended group versus 29 in the standard group. If you break them down into relapsing, recurrent, or repeat episodes in 6 months, you could easily appreciate actually there was a minimal trend of a trace of lower incidence of relapsing and recurrent episode in the extended group. But that's far more compensated by the high number of repeat episodes within the first 6 months in the extended group. And the complete cure was quite the same, over 60% in either group, not statistically significant. Now, this is a list of secondary outcome. We also go through the how many patients require hospitalization for the peritonitis, and 5 from each group require catheter removal, and conversion to hemodialysis. There were 2 in each group. In other words, for the 5 with a catheter removal, 3 of them in each group could successfully return to peritoneal dialysis with catheter reinsertion. 1 patient died of peritonitis in the standard group, and for mortality of all cause, 5 in the standard group, 2 in the extended group. The number was so small it could not be having statistical significance. 3 of them had mycobacterial peritonitis in the extended group, and 2 of them had secondary fungal peritonitis in the extended group. That is after completion of the antibiotic therapy, and actually after completion of the nystatin prophylaxis, which was used as a routine procedure for all of our patients. And this is the Kaplan-Meier curve summarizing the time to or the survival without a primary outcome. So the 2 groups intermingle, and there's no obvious difference between the standard and extended therapy. One of our original aim was to see whether bacterial DNA content in the peritoneal dialysis effluent could be used as a marker or predictor of relapsing or recurrent peritonitis, and whether targeting extended treatment to this group can help to prevent the recurrent or relapsing episode. Now, this is a complicated slide. Let me go through in a bit more detail. Now, if you consider for all the patients at the time of randomization, that is 5 days before the planned completion of antibiotic therapy, according to the ISPD guideline, the bacterial DNA level copy per microliter was the same between the standard group and the extended group. Now, for the standard group, they had their antibiotic were stopped 5 days later, and then we follow them for another 6 months and see whether they develop relapsing, recurrent, or repeat peritonitis within 6 months. And what we found was a relapse. Those patients who developed relapse or recurrent episode actually had a significantly higher bacterial DNA level 5 days before they complete the antibiotic therapy. This is expected. Actually, we show the same result in our previous study, which obviously were different patients. We use a different methodology to measure bacterial DNA, but the result was basically the same. Now, if we focus on the extended group, now this is at the time 5 days before their planned discontinuation of antibiotic. But since they were randomized to extend antibiotic, they had another 7 days of antibiotic therapy. So what we did was 5 days before their extended antibiotic complete. So actually it's from here another week. Before the treatment, after the treatment, we actually show that by extending the antibiotic therapy, the bacterial DNA content in the PD efferent really decreased. This is a pair comparison between before and after extended antibiotic therapy. There was a significant reduction in the bacterial DNA content in the dialysis efferent. Seemingly, numerically, there is effect. But what we found was for these patients, after another 5 days, the antibiotics, even though extended, have completed, and then we follow them for another 6 months, and some of them continue to develop relapsing, recurrent, or repeat peritonitis. And what we found was for those who subsequently develop relapsing or recurrent peritonitis, their bacterial DNA content before antibiotic completion was still significantly higher as compared to those without any problem. So once the problem is still there, you can interpret it as for those who are determined to have relapsing or recurrent episode, their bacterial DNA content continue to be high. And what we really achieved was for those who should do well, extended antibiotic therapy somehow bring down their measured bacterial DNA level in the efferent without any meaningful clinical benefit. And therefore, if we complete this group, for these two parts, they were both 5 days before the actual completion of antibiotic. And if we combine them, we actually see that those who subsequently develop relapsing or recurrent or repeat episode of peritonitis had a higher bacterial DNA content in the efferent before the antibiotic was completed. And the cutoff, I do not show you the ROC curve here. The cutoff would be around 2 copy per microliter of bacterial, 2 copy of bacterial DNA per microliter of dialysis efferent. So what, in essence, this is a negative trial. What we actually found was the distribution of causative organism was a bit different than what we originally planned. We actually, when we planned the sample size, when we designed the study, we expect, based on our previous experience, we expect a higher percentage of gram-negative, particularly Pseudomonas peritonitis, but that's not the case in our study. One possibility is because we actually excluded patients who were admitted for severe sepsis, high fever. Those were the patients more likely to have gram-negative Pseudomonas peritonitis, and we tend to exclude these kind of patients. And the sample size that we originally planned was 360, but at the end of the day, we could only recruit 254 because a large number of them were were screened out, and based on our study, based on the difference we observe in the relapsing and recurrent episode, we actually estimate that close to 1,400 patients would be required to achieve a 80% power to detect a difference between relapsing and recurrent peritonitis if extended antibiotic really could achieve something. And for the bacterial DNA content in the PD-Effluent, what we actually show is it is really a marker to predict a relapsing or recurrent episode, but a prolonged antibiotic can decrease the level, but it's only in those who will not relapse anyway. So it's not a really a gratifying result. So in summary, what we found was for patients with a PD peritonitis, extending the antibiotic for 1 extra week beyond the ISPD protocol should not be recommended. In an optimistic way, I can say, in other words, we somehow indirectly show that the current recommended duration of antibiotic is quite justified. And extending treatment does not reduce the risk of relapsing or recurrent peritonitis. Actually, it's associated with a slightly higher risk of repeat peritonitis episodes. So it does not prevent relapse. It may delay it for a short period of time. It's not beneficial in any material way. So thank you very much. But I will also like to take this opportunity to thank my unit and the Department of Microbiology of my university. And this is the funding source. I will particularly want to thank MC Law and Jenny Fong, the nursing consultant of my unit, who helped to coordinate the study. And Kathy and Peter did not appear in the offer, but they did quite a lot of work in managing the dialysis effluent samples and handling and optimization of the assay technique. Thank you very much.
Thank you, CC. That's where you normally get a round of applause but we don't have that luxury in obviously in an e-seminar. I think really important to provide information for the community. You called it a negative trial, but it's an important trial. It seems to affirm what the guidelines have previously supposed is the recommended treatment. I was once going to start with a question for Jeff, if that's all right. Jeff, I know you've been looking at usual practice around the world. How close is usual practice to ISPDN guidelines, and how might this trial change practice?
Yeah, so first of all, I want to congratulate Dr. Szeto on doing a randomized control trial in the area. I think it's exceptionally difficult, and we're really fortunate to have people like you help move the field forward. So first of all, a very strong congratulations. I think from my perspective, in peritoneal dialysis, there is sort of a matrix of 2 by 2. One is prevention and one is treatment. The other matrix is uptake of guidelines and knowledge translation. And the second is evidence generation, and where we don't have evidence for practices. So I think what I would have to say is that, we focused a lot of our efforts on prevention of peritonitis, and peritonitis rates have improved. But even still, the peritonitis still remains the leading cause of transfer to hemodialysis. And despite rates improving, we're still seeing very similar rates of adverse events following peritonitis episode as we did 5-10 years ago. And we just recently, with Dr. Al Sahlawi, finished a paper where we noticed internationally in the peritoneal dialysis outcomes and practice pattern study that only 64% of peritonitis episodes are successfully treated via cure. The rest have either a relapse associated with them, a recurrent event, catheter removal, death, or transfer to hemodialysis. So we have a long way to go, not only to prevent it, but also we still have to improve our treatment. So I'm really happy that Dr. Szeto focused on the area of trying to improve treatment and improve outcomes. I think what I would have to say is that even when we do have evidence for certain practices, they still remain poorly taken up across centers. So some of our grade 1A recommendations are antibiotics at the time of catheter insertion to prevent peritonitis, exit site antimicrobial prophylaxis with cream or ointment with either an aminoglycoside or mupirocin. And even still, when we did a survey published in NDT about 2 years ago now, we still found that there was marked facility variation. So I think we have two challenges here, where evidence is lacking in many of the things we do, and people like Dr. Szeto are advancing that, and also trying to improve the translation and uptake of guidelines across clinics. So lots of work still to do in that regard. But I think that your paper really will help move the field forward by us not routinely extending antibiotic courses for the purposes of preventing relapses. And I think that it's, and you've certainly shown some concerns with doing that in the first place. So I think it is a very important contribution to the literature.
Thank you. Great. Yeah, and I think we all echo that. Randomized trials and delivering that even in a single center is blood, sweat and tears. So Simon, you mentioned before when we were talking about some Australian data, the Australians follow guidelines with respect to the antibiotic treatment for peritoneal dialysis?
Yes, I mean, I think we all have to acknowledge that the Australian New Zealand group, the so-called ANZ data group, have probably done more than any other group to advance our knowledge and understanding of the field. And I guess perhaps for me, one of the most impressive findings that they've always consistently shown is this business of how much of the outcome of infections is associated with patient level factors versus facility level factors. And actually the data is particularly the case for the treatment of peritonitis as opposed to the prevention. But actually, they quantify that as, I think, something like 9% of the variation is associated with patient level factors and 66% associated with facility level factors. So in a way that that tells us immediately, I think, that actually it's the sort of stuff that Jeff was talking about that's really going to make a difference here in terms of getting better quality information, or better quality practice out there is going to make the biggest immediate difference in terms of those outcomes. I think what Jeff's already said is that CC's outcomes actually are in his own center, and it's a single center study, which is perhaps the only criticism I would have of it actually, is that your results are quite good in both of the limbs. Your cure rate was high compared to many centers, and probably you are, because you've had expertise in this area for some time, you're probably running quite good treatment interventions. You said you used fungal prevention in all your patients, all those sorts of things where your starting position. So we will have to bear that in mind when we interpret this data. I think what you have shown us, CC, is this is probably not the first trial or the next trial that we should do. We would not be to extend that trial and to try and do a bigger one. We should focus on something different. So it's a really valuable negative in that respect. But it also just reminds me to say that really in PD, the biggest challenge, I think, is still size and numbers of trials. This is a huge opportunity for me to plug the meeting that starts on Sunday and finishes on Tuesday. For those of you not yet signed up to it, it's a fantastic opportunity. This is the combined meeting of the EuroPD ISPD, which has been delayed almost a year because of COVID. It's a virtual meeting. And within that meeting, we've actually got a whole session devoted to clinical trial design for PD. We really want to try and think about that in some depth and detail. And it's going to range for things like discussing what are the right outcomes and endpoints to measure, through how can we work together as an international community to deliver trials, and therefore hopefully advance knowledge. Just perhaps if I'd be allowed just to ask a couple of questions to CC about the trial that I'm still not completely clear about. I should be, but I'm not. I mean, your catheter removal rate was something like 2%.
Yes.
Which is phenomenally good. And the question I wanted to ask was that because actually you were doing your randomization that must have been around about 10 days, 7, 9, 10 days of treatment?
Yes.
Because quite a lot of our catheters come out before 9 days. I mean, we've already abandoned the catheter. And do you think that is perhaps what, were you moving a lot of catheters in the early stages? Does that affect this outcome? Because you could argue that what you're trying to prevent is essentially reinfection from a persistently infected catheter. You know, the idea would be that there's some biofilm there, the bacteria which you're measuring the products of are sitting on the catheter. And is that something to do with what's going on here, do you think?
Yes, I think you're right. What we actually did, I don't think that was what we originally planned to do, but looking back, what we actually did was, as I mentioned, 40-something patients were not stable, and therefore they did not reach the randomization to decide whether they have extended antibiotic, because they were not doing well. They have fever. They have a very bad peritonism. And these are the patients who actually did not respond to antibiotic right from the beginning, and as a considerable proportion of them had catheter removal. Ending up, the patients who could be randomized into the two groups actually had initial improvement or initial response to the antibiotic. Obviously, a small proportion of them still worsen despite continuation of antibiotic, and that's why a small proportion of them still require catheter removal. But that actually result in the apparently a very low rate of catheter removal. Actually, because they all of them had initial improvement from the antibiotic therapy. I can honestly say the overall catheter removal rate of my center is not as low as such. It's just that since they could come to this stage of randomization, they should respond at least to a certain extent, and therefore the rate of catheter removal is very small. And so what, as you say, what we actually did was, since they responded, and the extended antibiotic would be, in a sense, to treat the persistent infection maybe in the biofilm attaching to the catheter, with an aim to prevent the relapsing or recurrent episode from this biofilm or adherent bacteria. I agree that's probably what we were doing in the study.
You previously had published from your center how predictive, I think, is the white cell count is at 2 to 3 days.
3 days,
in terms of outcome, which is a sort of an earlier stage of the process. And I just wonder whether you didn't present any white cell count data. And I just wondered whether that would have sort of helped explain that, whether actually these people, let's say 2 days in, still having a tremendously high white cell count, you had to take the tube out, versus was that still discriminatory later on?
Yes, our study used a PD-different white cell count at day 3 days after antibiotic therapy. Now, that's a predictor of immediate failure. That is whether they respond to antibiotic or not. And for our patients, by the time they could be randomized, all of them, the majority of them had the PD-different white cell count below that cutoff. That was 180. We usually use 1,080. We usually use 1,000 as the cutoff practically. And for the patients who could be randomized in our study, the majority of them, the PD-different white cell count was already below that threshold.
So I guess the specific question I would have then, CC, is what was the proportion of people in your criteria where they were clinically unstable that had their catheter removed? I mean, for me, it seems like good trial design. These people are not going to get to the point where you're going to need to randomize them to an extended antibiotic therapy or not. They're going to have they're going to have essentially a modality, or at least temporary or permanently changing event. So what proportion of those people roughly had their catheters out, and then
now there are 40 something, 44 patients. I think 12, if I remember correct, 12 of them had catheter removal.
Okay, that brings up the proportions of in your population as a whole. Muthana, you've looked internationally, obviously, and I think Simon's very nicely been questioning some of the generalizability. I think the study is standing up to scrutiny at the moment. Have you got any specific questions you wanted to ask CC?
Well, thank you. I want to first congratulate Dr. Szeto for conducting this RCT and thank him for presenting this interesting finding. So, so although there was no difference in the relapse or recurrent between the two groups, it is important to note that many PD units actually use intermittent dosing of antibiotics as opposed to what has been used in this study. And I think addressing the impact of continuous versus intermittent dosing of antibiotic on peritonitis outcomes can be very interesting and practical question to address, perhaps for future research. And I just have one question to Dr. Szeto also. After the result of this study, will there be any clinical implication of checking the bacterial DNA fragments in patients with peritonitis?
Now, if they have peritonitis, a high bacterial DNA level would suggest, at least before antibiotic is completed, would suggest they have a higher risk of having relapse or recurrent episode. So they are high risk group, but from what we have done or from what we could observe, we could do nothing to reduce that risk.
Really interesting, isn't it? Jeff, you had some questions about some of the trial design aspects. Did you want to ask CC about those before we address some of the questions from the audience?
Sure. I think so. CC, I'm just clarifying that even though there were 2 cases of fungal peritonitis in the extended antibiotic group, and we know that prolonged courses of antibiotics are a strong risk factor for fungal peritonitis, your center routinely used antifungal prophylaxis for all. So can you describe what your center does for antifungal prophylaxis, which is an ISPD recommendation in guidelines?
We use the oral nystatin solution, and the problem is that we use it throughout the duration of antibiotic therapy, but we stop it at the same time as the antibiotic. And what we observed, at least in this particular study, is we stopped the antibiotic, we stopped the nystatin, and sometime later they develop fungal.
Okay, so that's interesting because in our program, and I don't know that there's great evidence one way or another, we continue it 1 week after the antibiotics are discontinued, just to allow bowel flora to repopulate in that time. So I don't know if that would further reduce your antibiotic-associated fungal peritonitis.
Jeff, you may have a point. The practical consideration, at least for us, is I'm not sure about your patients, but because our patients do not like nystatin very much. They are very compliant to intraperitoneal antibiotic injection, but they're quite horrible in terms of
it tastes
oral nystatin.
Yeah, a patient asked me once to taste it because it's so horrible.
I taste it myself, it's horrible.
Maybe I think looking at these results, there is a real suggestion that there is harm associated. If you did a larger trial, there may be harm associated with extended antibiotics, both in terms of bacterial infections and fungal infections. I mean, the rates are very low. And maybe we ought to be measuring, evidence of fungal infection at the end of PD rather than evidence of DNA fragments. Okay, we have more questions by the looks of it, Jeff.
No, just one more practical thing. Again, bringing it back to ISPD guidelines for culture negative peritonitis. I think that the existing dogma was that it was largely due to undetectable gram-positive infection. So in some previous iterations of the guidelines, it suggested if the cell count was improving to continue only gram-positive coverage. But in my program, And I think in low and middle income countries, for example, in Thailand, we do know that a lot of culture negative may not just be gram positive. So in our program, we continue dual antibiotic agents for 2 weeks. I wanted to know what your practice was in Hong Kong in those cases that were culture negative with regards to the duration of antibiotics that were given.
We also use 2 antibiotics, continue both gram positive and gram negative coverage, partly because, well, largely because our previous data actually show gram negative organism is quite common. It is quite common in our locality, so we continue both.
Yeah.
Also,
and
the case in this particular study.
And then my last question is, practically, is there ever any indication to continue antibiotic therapy for a longer period of time? And I'll give you an example. Say that there's persistent effluent culture after initial treatment. Say this is a patient whose cell count takes a little bit longer to come down, a more challenging peritonitis. Would you just practically in your own practice continue antibiotics for a more difficult to treat, or would you sort of stick to the ISPD guidelines no matter what's evolving over the course of treatment with the peritonitis?
We will, at least I will continue a bit longer.
Okay, so there may be some, in select cases, for example, if the cell count is slow to come down or you've got it growing on a couple days worth of samples, there may be a role to increase antibiotic duration in an unevidence-based fashion.
Okay. Obviously unevidence, it just makes myself happier.
Right, okay.
I noticed you only had 8 patients who had a we had questions about tunnelitis from the audience, and I'm assuming that means an exit site infection in my language. So the proportions with an exit site infection in the trial were actually quite low. Is this again your amazing unit where you're able to keep these things under control before they or were these patients excluded because they had clinically unstable disease? Should we still be thinking about doing further trials of extended antibiotics for those who have got an exit site infection and perhaps this evidence is less generalizable to?
From a strictly scientific point of view, I think because the incidence of coexisting exit site infection actually is quite uncommon in our study. So I don't think we can reliably extrapolate our results to patients with concomitant exit site infection. And we didn't exclude them for the study, but honestly, over the past few years, the actual incidence of exit site infection decreased quite a lot in my center. I'm not sure, but our nurses did a fantastic job to teach our patients, and we are getting more and more meticulous to take care of the exit site for my patients. So it's really a genuine reduction in the incidence of exit site infection in my unit.
Simon, I'm sorry, I'm not going to make your meeting, but I really want to know what the big questions are and the big stories are in peritoneal dialysis at the moment. What is the next large trial to follow this trial by CC? Are there more trials in peritonitis, or are you thinking about other areas of the field?
Well, I think the truth is that peritonitis is still #1 problem, and actually, if you look at the latest Cochrane review, there's still far too many trials addressing this issue. So I think it still remains the low-hanging fruit for progress in PD. I would love to see, units working more collaboratively together, perhaps doing cluster randomized controlled trials rather than single center trials for lots of reasons, actually, but not least actually that they might be the easier way of doing it. I mean, we've almost heard today some examples of what you might do in that situation. You could randomize a center that has a different approach to exit site management versus not. For example, we are now managing all our infected exit sites by relocating the exit site with antibiotic cover, and we have very good results from that. rather than taking the tube out. So that would be an example of something that could be done but I think you'd have to do it at a unit level, because once you get used to doing that and you like doing it, you don't want to stop doing it. You know, it's difficult. But I think there is a trial going on at the moment in Australia and New Zealand. The one that they are doing is called Teach PD, and that's building on the idea that it is about competencies within centres. And competencies both of people on PD in terms of how they manage it, and also staff, and that'll be an interesting study to see how that comes out. So there's a number of things we can do, and the other thing I should perhaps briefly mention is also we shouldn't forget the Song PD effort around here, again led from Australia and New Zealand, but very much a global effort. And that's very much about, for example, defining the criteria of even what peritonitis is. So we really get consistency across centres and across trial centres and within trials as to precisely how you define your peritonitis, so that we then can move forward. And Jeff's doing some very interesting work on that with the PDOPs in the States. So there is progress, actually. I think we're beginning to make some effort now, but there's still a lot to do. It's a challenging environment to work in.
Okay, well, that's really nice to hear. I think it's time we call time on the seminar itself. So again, congratulations to CKJ Szeto for completing a randomized trial, randomizing 250 people and providing what I think are important results. It's not a negative trial. It's telling us something quite important about antibiotic therapy and PD peritonitis, which you've all shown to us really with your discussion tonight is really the key topic in peritoneal dialysis associated research at the moment. I thank again our key guests, Simon Davies from the UK, Jeff Perl from Canada, and Muthana Al Sahlawi from Saudi Arabia. We've got compliments from people on the quality of the seminar, so thank you very much. I think I've learned a lot about peritoneal dialysis. I certainly won't be extending antibiotic therapy in PD peritonitis, and I promise I'll follow the ISPD and PD guidelines, or at least encourage our unit to do so if we're not already. I think the bacterial DNA levels are an interesting bit of the science. I'd love to know more about how they might augment the information we're getting from white cell counts, and also I'm also interested in the sort of the fungal monitoring, if that was something for the future. Please do go to the CKJ website to see the paper. It's open access, available to all, but also there's an accompanying editorial which goes into some of the details discussed today. And we even have other articles. Professor Szeto, CC, has written already a review article about the newer antibiotics which might be used in PD peritonitis. And we have also an Italian centre's experience with fungal peritonitis. So please do go have a look at CKJ. And then please also consider joining us in March, when a team from Ghent University in Belgium will be introducing sleep disorders in dialysis patients, which will include information about their nocturnal in-center hemodialysis program. So we look forward to meeting you then, and thanks to all.